So let's talk about the knee as well as the ankle joint today. Okay. For the hip joint, please refer to lecture 1. So here you can see that the knee joint is closely related to several important muscle groups, particularly the quadriceps muscles. As you should recall, the quadriceps muscles consist of 4 muscles. Here we have the rectus femoris, and then we also have the vatus lateralis, as well as the vatus medialis, and this one is the vatus intermedius. Okay. So in the anterior view here we have the patella, and it is partially covered by the quadriceps tendon. This is the quadriceps tendon. Now may I remind you one important point regarding terminology of these dense connective tissues here. We call it tendon, but not ligament. Okay, so this is patella, and below the patella we have here, this is the patella ligament. Okay, some textbooks incorrectly refer to these as the patella tendon, which is anatomically incorrect. Remember that for the dense connective tissue with bone-to-bone connection or attachment, so we call it a ligament. So this patella ligament is actually connects to this tibial tuberosity here. And remember this tibial tuberosity, it is a very important bony landmark on the anterior surface of the tibia. Now the femur contributes 2 large condyles. First one is the medial condyle. I use the green line to highlight to you at the front and also at the back. This is the posterior wheel of the medial condyle of the femur. And also we have the lateral one. An important anatomical fact to note is that the medial femoral condyle, maybe we have to go to this slide. Yes, this one. So for the medial femoral condyle is actually longer than the lateral condyle here. Okay, so these differences in length forms the basics for an important locking mechanisms of the knee that we will discuss later. Now let's discuss the soft tissues in the knee joint. We have the collateral ligament, cruciate ligament, and meniscus. First, collateral ligament. So this is like the lateral collateral ligament, and also here we have the medial collateral ligament. And inside the joint, or inside the joint capsule, we have the ACL, which is the anterior cruciate ligament, as well as the posterior cruciate ligament. Take a look at the back here. We have the ACL, from the back to the front, as well as the PCL here. And we also have a fibrocartilage here, right inside the joint, which is called the meniscus. We have the medial meniscus and the lateral meniscus. Let's talk about the meniscus first. So the meniscus is a C-shaped fibrocartilage structures that deepen the articular surface of these the tibial petrol to better accommodate the convex femoral condyle. It's difficult to imagine, right? So take this one as the analogy. So take our egg here as the femoral condyle and the egg cup here as the meniscus. So with these meniscus here situated inside the joint, it can help to stabilize the round femoral condyle on the relatively flat tibial surface here. This one is relatively flat, but with the meniscus here, it actually helps to deepen it, and with a better articulation with the femoral condyles here. Now, the meniscus here serve several important functions. First, it absorbs approximately 1/3 of the knee impact load. They also help to stabilize the knee and also assist in the locking mechanisms. They allowed synovial fluid, right, to spread evenly across the joint surface, so to reduce the friction and also the stress on the knee surface. It also like prevent capsular and synovial impingement. It is important to note that the meniscus have a poor blood supply, so we say that they are relatively like avascular, no blood supply. So this means that if there is a torn of these meniscus, they have limited healing capacity, which has significant clinical like implication. So the knee alignment, we need to talk about it a bit. Okay. So normally the femur, so this is the femur. So normally the femur descends a slight like a inward angles here, right? And while the tibia like being straight downward. So this creates what we call the anatomical axis of the lower limb. So you can draw like this, right? A little bit inward. Okay. Now, what's happened when the knee is misaligned? So we describe the forces acting on it as either the valgus or a varus. Okay, let's take a look. The valgus force here is that if there is a force that applied laterally, it creates a lock knee appearance. You see that it's like okay. So on the other hand, when the varus force is applied, talking about apply to push the knees right medially, so we create what we call the bowed knee, right? Bowed knee. So at this diagram, you can see that the knee in extension versus flexion. You can see that the medial meniscus remains relatively stationary in both positions. It is not very mobile, as summarized in this table. In contrast, the lateral meniscus is more mobile in both extension and flexion. So these differences in mobility is due to two factors. First, the lateral meniscus has no relationship with the LCL. Second, the lateral meniscus is smaller with a tightened C shape, while the medial meniscus here has a wider C shape and is firmly attached to the MCL here. These differences in mobility explains why the medial meniscus is more prone to injury. When force is applied to the knee, the medial meniscus cannot easily move to dissipate the force, making it more vulnerable to tearing. Now the knee has approximately 14 bursae, but we will focus on 3 that have particular clinical significance. The first one is suprapatellar bursa. This is the largest one. It is located between the distal femur as well as the quadriceps tendon. An important anatomical feature is that this bursa, as you can see here, is actually continuous or communicates with the joint capsule, which means that inflammation of this bursa, which is called the suprapatellar bursitis, can affect the joint cavity as well. Now, these bursa, suprapatellar bursa, act as a cushion, permits free movement of the quadriceps tendon over the distal femur. It also allows for full flexion and extension of the knee. So repetitive trauma, overuse, or infection can lead to like these suprapatellar bursitis, and it results in severe pain and swelling. This one is called the prepatellar bursa. Prepatellar bursa. It is located subcutaneously in front of the patella. So inflammation of these bursa, usually we refer as a housemaid knee, typically resulting from a prolonged kneeling activity like floor cleaning. Another one you also have to pay attention is this one, the infrapatellar bursa. It is located below the patella. So inflammation of these usually refer as clergyman's knee, because seen in those who kneel for extended period, like doing prayer or religious activities. Okay. So let's discuss the knee locking mechanisms, which many students find challenging to understand it. When we fully extend our knee, like this one, when you're standing, okay. So take a look. Here, the flat surface of the femoral condyle aligns perfectly with the meniscus here, creating a stable articulation. However, in flat knee, the round portion or the curved portion here of the femoral condyles articulates with the meniscus, no doubt. But as you can see that here we have some rooms here, right? And these allowed certain extent of rotation. The knee locking mechanisms, also known as screw-home mechanisms, work as follows. First, as you can see here, the medial femoral condyle is approximately 13 mm longer than the lateral condyle. So when the knee moves from flexion to full extension, these lateral femoral condyle become fully accommodated in the lateral meniscus. But however, part of these medial condyle remains exposed because of the differences in length. Well, to complete the extension, the femur then slightly rotate medially on the fixed tibia. Now, these medial rotation can make this exposed part of the medial femoral condyle to be fully accommodated in the medial meniscus, that is, locking the knee in place. So when the knee is fully extended, the ACL, MCL, LCL, they are all tightened, providing maximum stability.
Femur on tibia, closed chain movement, lateral view. Femur rotates internally, medially to lock. Femur rotates externally, laterally to unlock. Locked. Unlocked. Femur on tibia, anterior view. Locked. Unlocked.
Why we need to lock the knee? Because it helps to provide stability and security during weight-bearing activities. It also allows for efficient transmission of forces, prevents unwanted side-to-side, anterior to posterior movement, and of course, very important, it reduces the risk of the knee injury. So to unlock the knee for flexion, a muscle called popliteus contracts. So popliteus contracts, and then it creates a lateral rotation of the femur on the fixed tibia. So this exposes the extra bit of the medial femoral condyle, the 13 mm portion, and loosen the ligaments like MCL, LCL, and ACL, allowing the knee to flex. Let's examine the cruciate ligaments in more details. These are intracapsular ligaments that cross each other within the joint, hence the name cruciate, meaning cross shape. The ACL originates from the medial wall of the lateral femoral condyle and then descend forward to attach at the anterior intercondylar area of the tibia. When the knee is extended, ACL is tightened and rigid, but it becomes loose when the knee is flexed. As a whole, the ACL prevents the tibia from slipping forward on femur, prevents the femur slipping backward on the tibia, as well as the hyperextension of the knee. The posterior cruciate ligament, PCL, originates from the lateral wall of the medial femoral condyle and then descends backward to attach at the posterior intercondylar area of the tibia. So the PCL is tight and rigid when the knee is flexed. The PCL prevents the tibia from slipping backward on the femur, prevents the femur from slipping forward on the tibia, and also prevents hyperflexion of the knee. So these, I hope you can at least recognize or appreciate the arrangement of the PCL and ACL. Because if you know the arrangement, where does it come from and where it attached to, it actually helps you that what is these ligaments for. Okay. Now let's down to knee joint injuries. So knee joint injuries are common because the knee is a low place, mobile and weight-bearing joint whose stability depends almost entirely on its associated ligaments and muscles. So ACL injuries are particularly common in young, active individuals. The ACL is weaker than the PCL, and that's why it is more prone to tearing. Most ACL injuries result from a non-contact mechanisms, such as a sudden changes in direction, causing the knee to rotate inward. Sports that involve pivoting, decelerating, and jumping have higher rates of ACL injuries. So the mechanisms typically involve a change in direction where the thigh, so this is the thigh, where the thigh moves anteriorly while the legs rotates laterally. So essentially it's like a twist in opposite directions, like a twist in opposite direction. So this often happens during a landing from a jump. Remember in the previous slide where we talk about in a fully extended knee, the ACL is already tightened. So these movements further strain this ligament, making it vulnerable to rupture. So after ACL rupture, the knee joints become unstable because the patients cannot fully extend the knee. These lead to chronic quadriceps atrophy. The quadriceps muscles waste away due to disuse. This is why rehabilitation focuses on strengthening the quadriceps through intensive physiotherapy. So when the ACL ruptures, patients typically hear a distinct pop sound. ACL ruptures are approximately 10 times more common than PCL ruptures. Let's discuss a common injury pattern called the unhappy triad. By understanding the close relationship between the MCL and the medial meniscus, we can understand how this injury occurs. The unhappy triad involves injury to three structures as follows. The first, the MCL, second, the medial meniscus, and also the ACL as well. So there are two main mechanisms that can lead to the unhappy triad. First, a blow to the lateral side of the extended knee. How does it work? Take a look here. So imagine a player whose femur is now medially rotated on the fixed tibia with the foot planted on the ground. If another player hit the lateral side of the knee, applying a valgus force, it can damage these three structures simultaneously. The valgus force applied to the lateral knee stretches the MCL because the MCL is firmly attached with the medial meniscus. This meniscus is also damaged. Additionally, the ACL, which is already tightened in this position, extended knee position, can rupture under the additional stress. The second mechanism is excessive lateral twisting of the leg when the knee is flexed. When the foot is firmly planted on the ground, like this one, like skiing, and the body rotates away from the fixed leg, it creates a powerful rotational force at the knee. This twisting motion places tremendous strain on all three structures. So doing this twisting motion, the ACL is trying to prevent excessive rotation of the tibia on the fixed femur, right? However, the force often exceeds the tensile strength of the ACL. Simultaneously, this twisting motion creates a valgus force, right, on the MCL, stretching it beyond its limits. And because the medial meniscus is firmly attached to the MCL, it gets caught in this rotational force and tears as well. So this twisting mechanism is particularly common in sports that require rapid changes in direction, such as football, basketball, and skiing. Think about when a player plants their foot to change direction, but the momentum of the body continues in the original direction. The knee experiences these dangerous lateral twisting force. Or you can imagine the foot is fixed on the ground while the upper leg continues to rotate, creating a shearing force across all three of these vulnerable structures. Patients with an unhappy triad typically required surgical reconstruction to re-establish joint stability and enhance function, regardless of which mechanism caused the injury. Ankle joint is another hinge joint. The talus is a critical bone that transmits the entire body weight from the leg to the foot. Its unique shape and position allow it to function as a pivot point for ankle movement, dorsiflexion, plantar flexion in particular. The ankle joint is formed by three components: the lateral malleolus of the fibula, the medial malleolus of the tibia, as well as the inferior surface of the distal end of the tibia. All these three structures together form a mortise, or you can say a socket, that articulates with the trochlea of these talus. So the trochlea of the talus is wider anteriorly and narrower posteriorly. Wider anteriorly, narrower posteriorly. So this form a very important foundation for you to understand why the ankle joint in plantar flexion is less stable when compared with in dorsiflexion condition. I find this image more meaningful for you, so capture screen and then put it into your revision notes. Now this is the talus with the trochlea located here, and here is the lateral and also the medial malleolus. Taking this as the zero position. So why we say that these anatomical features is very important to understand the functional implication? Think about it. When we the foot is in dorsiflexion like this way. So when we are in dorsiflexion, so this part will move right to the back, so making the anterior part of the talus fits tightly within the ankle mortise, making the joint more stable. Okay, what if the foot is in plantar flexion, right? So this narrower part the posterior narrower part of the trochlea is now within the mortise, so making the joint less stable. As you can see, more rooms, right, is allowed to have a certain extent of the movement. So this explains why ankle sprains commonly occurred during plantar flexion, because the joint is inherently less stable in plantar flexion. To facilitate your revision, I make this comparison table for your reference. So here you can see that during dorsiflexion, why we say that the ankle joint is more stable, because the wider anterior part of the talus now is wedging into the mortise. Whereas in plantar flexion, why we say that the ankle joint is less stable, because the narrower posterior part of the talus, which is this one, right, is forming the mortise, but they have more room for like movement, so making it relatively unstable. The foot has several joints that contribute to its overall movement. The first one here is the subtalar joint. It is located between the talus as well as the calcaneus. Next, we have transverse tarsal joint. Here you can see the transverse tarsal joint. Sometimes we also refer it as mid-tarsal joint. So these transverse tarsal joints include the following. Let me magnify. Okay, good magnification. So the transverse tarsal joints include, first, here, the green one, the calcaneal-cuboidal joint, together with the blue one here, the talocalcaneolavicular joint. So these two add up together, we have the mid-tarsal or transverse tarsal joint. Very complicated name, huh? However, it is always important to remember that the ankle joint only performs dorsiflexion and plantar flexion. Inversion and eversion of the foot occur at the subtalar joint as well as the transverse tarsal joint, not the ankle joint. This is a very common misconception. Bear in mind. The foot is arranged like a bridge with three arches. Here you can see the medial longitudinal arch. This is the lateral longitudinal arch, and also this one is the transverse arch. Now, if we talk about it one by one here, so for the medial longitudinal arch, the keystone is the head of talus, which receives and distributes body weight. For this lateral longitudinal arch, the cuboid is the keystone of this arch. For the transverse arches here, this arch is very important in distributing weight across the width of the foot. As a whole, these three arches serve several functions, like they support and distribute our body weight, they act as shock absorbers during walking and running, they help propel the body forward during locomotion, they also maintain balance, especially on uneven surface. You may have to exercise these arches to make our body at a good balance. The stability of these arches depends on several factors. First, give thanks to these wedge-shaped bones that we have. So because of this wedge-shaped arrangement of the bones, we laterally forms the arches here. So take the talus, right, as an example. The second is because of these plantar aponeurosis, which acts as a tie beam, right? Like a tie beam in architecture, it connects the two ends of the arch and prevents them from spreading apart under pressure. Now, third, we have these plantar ligaments, short and long plantar ligaments, and show here this is the long, this is the short, and these we have the spring ligaments. So these ligaments, they act as like staples. So here you see the staples. Okay, these ligaments anchor the bones together, preventing displacement when force is applied. So here you see is the suspension bridge. We also have suspension bridge in Hong Kong, Chiang Mai Dai Kio, and here you can see that a lot of this suspension providing support, right, to keep the bridge in shape. We have similar measure to support our plantar arch as well, which is by the tendon of the leg muscle, because their tendon run either under the foot, like this one, the fibularis longus, or the insertion point is either on the medial or lateral longitudinal arch, which also provides support to the arches. So let's talk about passive and active support to the foot arches. So we refer passive support comes from non-contractile structures, including the bony configuration, the plantar aponeurosis, as well as the plantar ligaments. So all these contribute to passive support. And for the active support, it comes from muscles and tendons, as you can see here, the tendons, the muscle here. So these contribute to active, or sometimes we refer it to dynamic. So it is important to help maintain the arches dynamically, especially during movement and loading. So now here, take a moment again to observe this image and visualize how these muscle tendons will contribute dynamic support to different foot arches. Okay, so besides producing movement, so all these muscle tendons also help maintain the arches when the foot is loaded, especially during walking and push off. So here I have marked the tendon with red star, so to highlight the ones I especially want you to pay attention to. Let's look at the key plantar ligaments that support the foot arches. So this is the long plantar ligament. It stabilizes the lateral longitudinal arch. Deep to it, we have the short plantar ligament. And also on the medial side, we have the spring ligament, or call it the plantar calcaneolavicular ligament. Particularly, this spring ligament is crucial for maintaining the medial longitudinal arch and preventing flat foot. So altogether, these ligaments act as the staples, right, that anchor the foot bones together, preventing displacement when force is applied and helping to transfer weight from the talus to other parts of the foot. To secure the arches, we have several strong ligaments to protect the ankle joint both laterally and medially. So lateral first. First, here we have the anterior talofibular ligament. As the name tells you, right, it is trying to secure the lateral malleolus here with the talus. Okay. Next, we have these posterior talofibular ligament, also secure the lateral malleolus with talus posteriorly. Okay. Third, we have the calcaneofibular, this one, the calcaneofibular ligament, which secure the bottom tip, this one, the bottom tip of the lateral malleolus with the calcaneus underneath it. Okay, so three all together provide lateral support. So on the medial side, we have a group of ligaments. All together, we call it deltoid. So deltoid ligaments, they are very strong. And with these deltoid ligaments, they can attach the medial malleolus of the tibia, firmly attached with talus, with calcaneus, as well as these lavicula. So let's take a look. So there should be 1, 2, 3, 4, 4 members in the deltoid ligaments, right? But of course, these 3 are the major one, very obvious one. So this one relatively tiny, relatively small. Okay, take a look. But yeah, I guess you guys are very smart. You see that we have a posterior tibial talar, which means that we must have a anterior compartment, anterior counterpart here as well. So the anterior tibial talar ligaments, right? So both of these attach the tibia with the talus. We also have the tibial navicular here, as well as these tibial calcaneal here as well. So altogether, it provides a very firm attachment on the medial side. So by knowing the size of these ligaments, right, on the medial side versus the one on the lateral side, I hope you know that the deltoid ligament is very strong, as mentioned here. And these can also explain some of the presentation in ankle joint injury. So the acute sprain of the lateral ankle is the most common ankle injury, like contribute to more than 90% of all ankle sprains. So 拗柴啊, okay? So you imagine that the foot is forcibly inverted, right? Forcibly inverted during transfer of weight into the plantar flexed foot, which is an unstable foot, right? Remember, plantar flexed foot, right, is less stable when compared with the dorsiflexed one, okay? So this one referring to forcibly inverted foot. So these actions, it can partially or completely tear off the lateral ligaments, in which this one, the anterior talofibular ligament, is most commonly torn in ankle sprains, right? Either partially or completely. Okay, so it will result in unstable ankle joints, great pain, as well as local swelling, right? So the boys, right? If you are very sporty, you like to play sport, somehow you might have this once or twice. Okay. So in severe cases of excessive inversion together with plantar flexion, so the strain on the lateral ligament may be forceful enough to cause these a avulsion fracture of lateral malleolus, which is quite commonly seen in sports injuries such as basketball and soccer. Acute sprain of the medial ankle is quite rare, right? It is caused by the foot forcibly everted, like in the sport ankle. Can you see this? Right. So this here, the foot here is being right excessively everted. Okay. So remember the deltoid ligament on the medial side here. So one feature that you cannot miss is the strength. They are very powerful. They are very powerful in a way that when there is the ball, right, the force, okay, you can actually keep in good integrity, then it pull off the distal bit of this medial malleolus here. So the medial malleolus is fractured or can be fractured because of the strong pull of the deltoid ligament. So take a look here. We have a very strong syndesmosis that bind the distal tibia as well as the fibula together. So think about it, when the first part here is being torn, and then the talus will move laterally, and because of these tightly bound together, so the force may either move upward, right, transfer upward so that to fracture the fibula, or the force like transfer a little bit downward, and then so that the lateral malleolus may be like fractured. So for this part, just give you an idea, right? Sometimes the presentation of the disease or the fracture, the dislocation case is very anatomy oriented. You have to know the basic anatomy so that you can understand, right, the presentations in the clinical setting. Okay.